When patients are treated for head and neck cancer, they almost always have a salivary gland that is in close proximity. Because if you think about it, if a salivary gland is in your cheek and in your jaw, you can't imagine very many places within your mouth that they would treat with radiation, treat the cancer with radiation, and not hit one of the salivary glands. And it's not well known why salivary glands respond so sensitively to radiation, because in the grand scheme of the rules of radiation, they shouldn't. And these patients have one of the poorest quality of lives of any cancer patient. Can we restore function can we understand anything about restoration of function? And can we start to move that towards clinical application? And so what our particular grant was looking at was one of a newly described process called autophagy. And basically what that is a cellular recycling. So if there's something damaged in the cell, it can recognize that, recycle it, and continue on living. So it's really, in our mindset, it's a survival mechanism. We're a little bit biased, but we think everything starts with the salivary gland. So if you're up giving a talk, your mouth gets all dry. That's probably stage one of annoyance and side effects. But these people constantly have that dry effect. Now think about if you put in a piece of gum into your mouth. That's a bunch of saliva that's stimulated because you're eating, you're chewing. That also doesn't happen in these patients. So it's very difficult to swallow if everything is dry. It's very difficult to start digesting your food if you don't have any saliva. The whole point of saliva is to protect your oral mucosa around your cheeks, around your gum line, and so you'll start to develop canker sores. But they don't go away, and so they persist, and everyone knows how annoying one is. I couldn't imagine having a mouthful of them. And so a lot of these patients, one, are constantly carrying a water bottle because they're always dry, and two, what they eat is modified. In other words, you wouldn't have a cracker very often, and eventually that starts to affect their diet. And there's a fairly high percentage, I think it's around 35%, that end up having a tube feeding placement. Most of the patients are getting concurrent radiation and chemotherapy. There are some that will get surgical resection and radiation alone. Some that's dependent upon how advanced is the tumor. But a lot of them are getting chemotherapy and radiation concurrently because head and neck cancer has a very high recurrence rate. And so a lot of times oncologists that I've talked to will take a broader field of radiation because they are very concerned about it coming back. Which also makes a broader field within the mouth and more salivary gland damage. And that's understandable. Your primary goal is to get rid of that tumor. And then worry about the side effects later. The problem is the side effects can last 2 years. Sometimes if they give it a lot of radiation, they're permanent.